This meeting is now being recorded.
Okay, so we are going to begin the recording. I'm going to have Dr. Litterdale and Dr. Hudson do a brief introduction of themselves, and then we'll go through the PowerPoint. So welcome, everyone, and I'll turn it over to you, Dr. Hudson and Dr. Litterdale.
Good afternoon, everyone. Happy to be here to be able to share with you a little bit of our knowledge and experience in treating chronic pain. If we can go to the first slide, or the next slide. Basically, what that is just telling you about me. I am a family physician by training, and I have been working since 1982 with a multidisciplinary pain rehabilitation program at Mary Free Bed Hospital. And I kind of fell into that by accident, but along the way have become a fellow of the American Board of Pain Medicine, a member of the American Pain Society and the National Headache Foundation, and our programs, there we go, got the next slide, and I'm working at starting another pain program at a federally qualified health center here in Grand Rapids as well. That is not up and running yet, but we hope it will be in the near future. So I worked and did family medicine until 2010. I couldn't balance both of them at the same time, and so since then I've been doing strictly pain management. And I'm going to let Dr. Litterdale, my colleague here, introduce herself.
Okay, hello everyone. I can go to the next slide and it will give you a little bit of information about me. I'm a licensed clinical psychologist, and I've worked in the mental health for over 20 years as a psychologist since 2004, I believe. Sometimes I don't want to remember that far back. But I came to work in the pain center here at Mary Free Bed as a pain psychologist, and I have really enjoyed working on an interdisciplinary team, as my background was working more in private practice. And I've been going around with Dr. Hudson, and we've been kind of sharing information about our program, but also our vision for how to treat chronic pain moving forward.
How are we doing volume-wise? Is everybody able to hear us both?
It's still a little faint and a lot of crackling going on.
Okay, we'll move closer to the microphone and try and up our volume a little bit. Let's have the next slide. These are some objectives. Melissa and I are just learning about your group and who you represent and case management. So we're trying to focus our talk today on ways that we think would help you the best, and we certainly would like your feedback as we go along. Go ahead with the next slide. All right, let's talk about pain. Pain is something we all have experienced. It's pretty rare to have someone who can't feel pain, although they do rarely occur. It's really been in recent years, as we've tried to unlock some of the secrets of our nervous system, that we've realized that this is a much more sophisticated system than we used to think. We used to think this diagram shows the central nervous system consisting of the brain and spinal cord and the peripheral nerves, this one showing the peripheral nerve going out to the fingertip. And we used to think that if you took a hammer and smashed the end of your finger, that nerve sent a message up to the spinal cord. It could send a reflex message back to the muscles of the arm that would cause a reflex motion. And then the impulse would go all the way up to the brain, where it would be processed and sent to the somatosensory cortex. The somatosensory cortex is the area of the brain where we know the peripheral nerves send all of their messages. And it turns out that that part of the brain is organized anatomically, meaning that every part of our anatomy has its own cells that correspond with that in the sensory cortex. So if I hit my right index finger, there's a spot on the left side of my brain where those messages go. And we used to think, well, that's what pain was. It was just that message going there. The harder you hit the finger, the more the pain, and that's all there was to it. Turns out to be much, much more complicated than that. We now refer to that situation as nociception. Nociception is the input into the brain. We also know that this system has inhibitory and excitatory neurons along the way in the spinal cord and in the brain stem that can, at times, almost completely block that nociceptive input or can magnify it. You know, like any kind of a magnification, a rheostat that can turn the volume way up on it. And that depends on prior history, what we used to think about this pain or what we're thinking presently, what's going on in our life right at that moment. I like to tell some stories because this tends to be what people remember. My first job in medicine was when I was an undergraduate at Western Michigan in Kalamazoo. I got a job at Bronson Hospital as a phlebotomist, drawing people's blood. After I'd worked there a few months, one day the football team from Western came in. They were doing some tests on all these guys, and I'm drawing their blood. And it turns out 2 of them pass out when I draw their blood. I think, well, no wonder we don't win any games, huh? So, of course, you could see looking at these guys that they were in trouble. They're sweating, they're squirming in their chairs, they're going, oh man, I really don't like needles. I really don't know why I have to do this, you know, and boom, let's go. Okay? But they weren't wimps. If you'd said to those same guys, how about some football? They would have said, hey, I can't wait to hit somebody. Even though that would cause much more nociception than me poking them with a needle, their response is completely different. Okay? Because a number of things. Probably as a child, they had an injection that they weren't well prepared for, and they became scared. And that fear carried all the way into adulthood. So as soon as the coach tells them, you got to get your blood drawn, they start thinking, oh man, I don't know about that. I'm not good with needles. And they were worried, and so a basket case before I ever touched them. On the other side of it, every time they played football as a child, their dad told them how great they were and took them to McDonald's afterwards, and they got trophies for their bedroom and their pictures in the newspaper and money to go to college. So they downplayed any pain associated with football. And that is really what determined the pain they felt in those 2 situations. Okay? So this gives you an idea of how complex this system is. And the good thing about it is it can change. And that's why a program like ours will even work, because there is a plasticity in the nervous system that allows the nervous system to change how they react even to the same thing. So that if one of those football players got diabetes and was poking himself with a needle 3 times a day, very soon he'd be going, geez, I can't believe I used to be afraid of needles. I hardly even feel them anymore. Another example I use of that is my daughter who moved to Chicago. She got an apartment right by the L. Why would she do that? It was cheaper, right? She was going to save $100 a month. She wanted to buy a house. But this train was so close that the building would shake, and it was so loud that you had to stop talking while it went by because you couldn't hear each other. So she says, I don't know, Dad, this might not have been a good idea. I don't think I can sleep here. Within about 2 weeks, she finds herself sleeping through the night. Even because her nervous system can take in that information, say, you know what, it's the same old train. She doesn't really care. She's saving $100 a month. We'll let her sleep. That same daughter doesn't live by the L anymore. She saved enough money to buy a house, so she and her husband moved to another part of the city. But they had their second baby girl. Little Nora was born a year ago, and when Nora would make a little noise during the night, she'd wake right up. Okay? Didn't have to be very loud. This is how good this system is. It can determine whether it's a sound you want to hear or you don't want to hear. You can get used to it. I had an elderly patient come into me a couple of years ago. He was all bent over, leaned forward. He couldn't straighten up at all. He kind of limps into the exam room and says, "Doc, I'm really glad I got to see you. You got to help me with this pain." I said, "Well, tell me about it." He says, "It's my arm. I have this terrible pain in my arm, and I've seen 3 different doctors, and nobody can tell me what's wrong." I said, "Well, what about your back?" He kind of looks surprised and says, "Oh, my back's been like that for years. That doesn't bother me." And he had a worse back than almost everybody we see with back pain in our clinic. He couldn't straighten up at all. But it wasn't bothering him. The pain output his nervous system was giving him really didn't bother him at all. And this just gives us an idea of, okay, how we think about the pain is actually more important than the nociceptive input. And that's very important to realize. And so how we approach patients is very important. There have been a number of studies now that have looked at MRIs of the cervical spine and the lumbar spine and say, okay, can we have our radiologists and our neurosurgeons predict who's going to have the most pain from this? And it turns out they're not very good at all. They can't predict who's going to have pain based on what their imaging studies look like. But we can begin to predict that from some psychological questionnaires that we do. And Dr. Litterdale is going to talk to you about that a little later. Let's have the next slide. So we've talked about nociception versus the pain experience. The input to the somatosensory cortex from the periphery and the spinal cord, and the fact that pain is really more of an output of the central nervous system rather than an input. And the brain gets to decide how much of a pain output to do, and it's basing it not just on nociception. Nociception is neither sufficient nor necessary to experience pain. Another thing that kind of led us to these conclusions was the whole experience with phantom limb pain. Phantom limb pain, of course, is when someone's had an amputation and feels pain in their missing limb. Obviously not a problem with the limb itself. It's not going to do any good to get that arm out of the trash heap and do something to it. It's not attached. It's not playing a role here anymore. It's the nervous system, and specifically that somatosensory cortex and possibly the spinal cord, that is leading to this persistent pain even in the absence of that limb. Okay, let's have the next slide. Any questions about what I've said so far? Okay, I'm assuming everybody's still out there, and we'll just keep talking. Some very interesting work is being done on chronic pain now, and I wanted to just put up here a couple of references. Dr. David Butler and Dr. Lorimer Mosley are 2 Australian physicians. Well, actually, Dr. Mosley is a PhD physical therapist, and they've done a lot of work on chronic pain, and they have some very interesting YouTube videos. And if you search for their names under YouTube, you'll find some of their videos. Dr. Mosley has a great TED Talk on there. I really recommend that to you. Also, Dr. Daniel Claw is a rheumatologist at the University of Michigan, and he was on the panel that first came up with the diagnostic criteria for fibromyalgia. He has a 90-minute YouTube video that you can watch, too, that goes over some of this stuff in more detail than I can do today. But I recommend that to you. Next slide. All right, let's talk a little bit about acute versus chronic pain. Acute pain is, some people say, the normal sensation in the nervous system that you get from an injury. Although even acute pain is modulated by these inhibitory and excitatory neurons. but it does serve a purpose. It alerts you to possible injury, need for action, and it's identifiable and localized. Chronic pain, on the other hand, is persistent pain that really persists beyond the usual healing time. And often, chronic pain over time gets worse and worse, even though there may not be any evidence for unresolved problems. And we believe that there are changes that occur in the nervous system for various reasons that cause this to be continued on a long-term basis. Next slide. 1/5 of primary care patients are affected by chronic pain, defined as pain present most of the time for 6 months in the previous year. It's a huge problem. It's one we need to get our hands around, especially if we're going to be involved in population health, where we're responsible for the cost of care of a population of patients. These patients cost a lot of money. Johns Hopkins did a study of how much really the chronic pain costs us, and this $635 billion a year is actually more than what cancer costs, or heart disease, or diabetes. So it's huge, and we really haven't spent much time looking at how to control those costs and how we ought to be best treating this problem. Next slide. Just kind of going over that, the other thing is, in the last 20 years, there's been a lot of changes in how we treat pain. And it really kind of came on after Dr. Kevorkian kind of challenged the medical profession and said that, you guys really don't care about these poor people who are suffering. I'm the only one that cares. And after that, there was a big push to be more aggressive in treating chronic pain. And unfortunately, there were some unintended consequences. JCO came out with this pain as a vital sign proposal and said you've got to ask all the time, you've got to respond to anybody with pain. And an unintended consequence was that there was a huge rise in the use of opiate medication and opiate overdose and death. And that really, almost every state in the union has developed a big, huge public health problem regarding this. In March of this year, the CDC came out with recommendations for the use of opioids in non-cancer pain, and I'd like to spend a little time on that. Next. In their recommendations, they start out by saying there is no evidence that shows a long-term benefit of opioids in pain and function versus no opioids for chronic pain, with outcomes examined at least 1 year later. The placebo-controlled trials on which they based the recommendations to be more aggressive in using opioids were generally short-term studies of 6 weeks or less. They also tended to exclude anyone with a prior history of substance abuse or with mental health disorders. And yet those tend to be the people who end up on chronic opioids. And to date, between 1999 and 2014, there have been more than 165,000 deaths from overdose related to opioid pain medication in the United States. So this is not even including those who died of a heroin overdose when they could no longer get their prescription opioid. So if anything, it underestimates the problem. Next slide. The CDC then listed 12 different recommendations. They said, we don't see any evidence that opioids help. We see lots of evidence of harm. And then they proceed to tell you how you should go about prescribing these drugs. So they really don't tell you what else to do. So we're going to give you an alternative approach here today. and that would be a rehabilitation model. When we see patients with chronic pain, we don't focus on getting rid of their pain, which seems like a funny thing not to do if you're a pain program. But our rehabilitation model focuses on helping people get their lives back. And this is no different than what we do in someone with a spinal cord injury or a stroke. We don't have cures for those things. Our goal is to have them be the least disabled as possible. And that really includes psychological disability as well as physical disability. Because you can imagine if you were a paraplegic or quadriplegic, that the mental part of that recovery would be every bit, if not more important, than the physical recovery. How am I going to deal with myself being in chronic pain? So that's the approach we take in our pain programs, which are outpatient programs in which focus on people who are being disabled by chronic pain. And we say, they come to us and say, Doc, you get rid of my pain, I'll get my life back. But we say, well, tell us what that life would be like. Tell me, what is it that you want to do that you're not doing anymore because of your pain? Is there a way we can move to getting that back into your life, even with the pain? And so it's a different approach. It's not saying, well, let me give you a shot there, or let me do another surgery, or let me up your dose of pain medication, because we found that those things really don't work. And that's where they get stuck in this cycle of trying to fix the pain. Next slide. Really, how a person reacts to their pain, and I have my own little pain problem. I've had migraine headaches since I was in college, and it really was, I never found any medications that would get rid of my migraines. The triptans didn't work for me. And I would always end up vomiting until I learned how to react to having the migraine differently. How I reacted, I thought, was reasonable. I would go home and go to bed. I'd lay in bed thinking that was the best way to relax. But I really wasn't relaxed. I was fretting. I was thinking, oh, no, not again. I can't stand this. This is going to be another night. It's going to be terrible. I got a big day tomorrow. And sure enough, I'd wake up vomiting. I had to learn that it was much better for me to stay up and active and consciously relax and look at my day and pace myself through the day. Once I started doing that, I stopped vomiting altogether. And gradually, the amount of pain I felt with my migraines decreased to almost nothing. Now I get my aura, but I get almost no pain with it whatsoever. So we need to understand how the system works and how we can use these tools to function better with whatever our pain problem is. Next slide. Our programs, we have a team. I have myself as the physician. I have a physician assistant who's very good, and we have our nursing staff. We have pain psychologists who are focusing on the whole psychology of pain, and Dr. Litterdale is going to talk about that in just a few minutes here. We have physical therapists and occupational therapists. And I have to tell you that our PTs and OTs are a special breed as well. These are people who really wanted to work with chronic pain patients, and they do almost as much of the psychotherapy as our psychologists. And really, our psychologists are key people on our team, and they inform myself, the medical team, as well as the PT and OTs in terms of how we need to deal with each patient, because each patient is different and unique, and it requires finding out, about that unique individual before we can really help them. Next slide. I'm going to skip that slide. Let's go to the next one. I think in our medical system, when you have a complex patient, that one of the problems that they can see is that they get referred from one specialist to another from the office. And those specialists are often not communicating very well. And so the patient may be getting different advice from each of the person on their treatment team. And they don't know what to do. When we have our program, because we're all located in the same place, we're seeing the patients concurrently so that they often have multiple appointments in the same day. We meet every week and discuss each patient who are having trouble. This allows us to give a consistent message to the patient, which they greatly appreciate. Next slide.
So cute.
Next slide. That's usually the message we are giving, by the way. The physician and my nurse practitioner, my PA, we believe that there is no benefit in chronic narcotics. And so it's always a goal to get all of our patients off of narcotics. And this is not a new belief on our part. It's one that we've held through the whole 30 years that I've been working. Don't do injections or invasive procedures because it kind of short-circuits what we're trying to do with the patient and helping them learn to manage this on their own. We also even try to avoid any passive physical therapy approaches because we want the patient to understand their body and their nervous system and to develop the skills they need to manage their chronic pain. There's a lot of education, a lot of support. Okay, next slide. This is back to the CDC recommendations. I think we've kind of covered that. We do, when we take people off narcotics, we do it slowly, not extremely slowly. I also go over with patients, we have what we call a COWS scale. That's a clinical opiate withdrawal scale. It's a form I can give them that, and if you Google it, you'll find it online, that has symptoms of withdrawal from opiates and a way for the patient to score themselves, find out if they're in mild withdrawal, moderate withdrawal, severe withdrawal. We tell them we want to keep them in the mild range. I give them my pager number and my cell phone number so they can get a hold of me 24 hours a day, 7 days a week while they're going through this, and that's a very therapeutic thing to do. I get very few calls, as a matter of fact. I probably don't get more than a couple calls a month, but you have to understand they're being seen 2 or 3 times a week by the staff and usually by me once a week when we're withdrawing them from narcotics. Next slide. We do follow up with them after discharge. Actually, it's usually more like 60 days now, but each person is individual on that. Next slide. I'm going to go over to Dr. Litterdale now so that she can kind of tell you from a psychologist standpoint what our programs are like.
One of the biggest questions, and I think for some patients, reluctancy to participate in our program is, I do not want to meet with a psychologist. The pain is not imagined, it's not in my head, and they have all other kinds of stereotypes about what psychology means. We really do try to educate them from the beginning that all pain is sensory and emotional. So it's coming from their body and also involving their mind, but also all of our mind functions, our cognitions, our sensations. So we really work along with medical, and actually all of us, PT, OT, really explaining to people why. Why is it that we have you doing this activity? So the question about why psychology is involved is often a big obstacle. So I'm going to explain it a little bit in hopes that if you're making a referral to health psychology, pain psychology, or a program, that you'll be able to speak with your patients in a helpful way. Next slide. So Dr. Hudson already discussed how emotional pain and physical pain, the body and the nervous system are registering them in a very similar way. Our interpretation of the signal makes a huge difference. But we also understand that the same neurological pathways within the limbic system and other areas of the brain are lit up. And it's almost like the emotional pain signals are traveling the same highway. So when you get somebody who has a lot of emotional distress combined with physical pain, they're more likely to have a difficult time readjusting their nervous system and being able to cope. There is a high comorbidity between psychological disorders and chronic pain. Depression and anxiety are two that we see a lot. We also do see a lot of bipolar disorder that has been masked and undiagnosed due to narcotic use. And I think personally, talking with a psychologist, any history of trauma, whether that's like car accident or interpersonal trauma, is going to make a person more likely to experience chronic pain. Dr. Hudson mentioned the psychological factors are more predictive than a lot of imaging and tests. And one of the big reasons is pain catastrophizing and pain avoidance. As a culture, we have belief systems around pain and discomfort are to be avoided, and if we experience them, then we're not happy, and if we're not happy, something must be wrong with us, and the snowball continues. The psychologists were talking with people about their relationships, how does the chronic pain get in the way of their relationships, and then the quality of life or functional concerns. Next slide, please. We really do believe and continuously give a person the message that pain does not equal disability. And again, kind of educate. I had a patient who came in and he had been struggling with chronic headaches and vestibular disorder. He had given up working and all of his hobbies because he would fall over unexpectedly at any time. So he was very angry, very depressed. In the process of working with him and kind of getting him to understand what was going on with his nervous system and understand the other things in life that he lost due to the pain in his health condition, he didn't really have to lose all of it. He slowly began to engage in activities that he could find, where before it was like, nope, I'm not even going to do that because I can't do it like I did before. Golf was an example. I can't golf. I can't even pick up the club because I'll fall over. Well, him and I talked about making a plan. Okay, let's get you just hold that golf club and hit the putter inside the house. He's like, no, I'm not going to do that. 2 weeks later, physical therapist tells me, oh yeah, Mr. So-and-so was talking about how he was hitting his dog toys with his putter in his house and how it made him laugh. So from there, he began to really open up and look at that. So we really try to get people to experience that they can accommodate and adjust to their condition. Next slide. So one of the things that we do a full psychological evaluation, and we use a lot of testing instruments. Some of the testing instruments are the Beck Anxiety Inventory, the clinical CDI, and the CED. I can't remember the full names at this moment. The other ones that are really speaking to our approach to working with people are the Chronic Pain Acceptance Questionnaire and the Pain Catastrophizing Scale. Those really kind of look at a person's pain willingness, their willingness to have pain in order to stay engaged in activities they value. And they also look at how much they feel helpless or ruminate about their pain. And those two instruments really, if we look at that and someone is very high, we know it's going to be hard. Even at the end of a program, someone who scores high on those is still going to have work to do, most likely. What you see in the slide in front of you is an example of the pain scale. It is still in press and has not been published yet, but it has been used in research, especially research involving imaging and also physical therapy. It was found to predict who would do well with physical therapy interventions versus who would continue to have pain after traditional treatment course. So as you can see, there's just examples, blaming yourself for things, feeling lonely or blue. So really speaking to the reaction to the pain. Next slide. Again, more sample of the items. Next slide. And then this speaks to pain as we experience it. It triggers an emotional response, but also that behavioral activation. So somebody, you touch something hot, you move. So even with chronic pain, there's this tendency for us to want to do something about it. So these, on this slide, they talk about, I want to get rid of the pain, I can't keep my mind off of it, I keep thinking about how much it hurts. So that's where it, again, becomes more of a complex psychological issue as someone's behavior becomes thinking and overthinking and analyzing their experience. Next slide. So what we do more specifically is we teach skills to overcome stress, depression, anxiety. We have incorporated a mindfulness approach, which is coming out of a lot of work in pain clinics throughout the country. And we use acceptance and commitment therapy to address pain and life values. And I'll speak about that a little bit in the next slide. Biofeedback is also a part of our program, which really builds a mind-body connection for people. So acceptance and commitment therapy, not sure how many people are familiar with this. It is a form of cognitive behavioral therapy, but the goal is to not get rid of the negative thoughts or not to get rid of the pain. The goal is actually to learn to coexist and accept them and direct our behaviors towards our values, to commit action to what matters to us. So next slide, please. This is a diagram that kind of shows the aspects of ACT. So the acceptance, accepting the pain, accepting the emotion, the diffusion, being able to detach from having an emotional reaction to thoughts as they arise, or to engage in storytelling. To understand self as context. Who you are today is different than who you were 2 years ago and who you will be 2 days from now. Committed action, again, what are your behaviors and do they reflect your values? The values, what's meaningful? Oh, I want to garden. I want to go interact with my grandchildren more often instead of sitting here and being numb because of the medication or because the pain is too much. So we really work with people on finding ways that they can live their values out. And then the mindfulness brings the present moment context. So even though you're having pain, can you connect with the present moment and your values? And ACT is very different from CBT, because if I told you all to not think about a pink elephant, how many people have now a pink elephant in their mind? And the more you try to not think about it, the more that will be there. So this is just saying, oh, look, I'm just noticing there's a pink elephant, a thought of a pink elephant. So it's a much different approach. Next slide. The biofeedback that we use is also in the service of teaching the ACT principles, but also educating about the nervous system and how what they think or their emotional state increases the fight or flight system, increases physiological response. So we do a lot of work with respiration, and to me that is one that I cover a lot because I think it's key to teaching them about mindfulness and guided meditation and why it's important to actually do the activities, because they can experience getting themselves in a very calm state through breath. The GSR measures sweat response, and again, it is very interesting. I'll have people sit there, hook them up, and then tell them to have private thoughts they don't say out loud about something good. We can see the response and how it escalates, and then to have them think about their pain, they're not saying it out loud. These are just thoughts that are controlling the nervous system. So then we instruct in relaxation techniques, and throughout the program are kind of blending that into the therapy that we do. Next slide. Are there any questions about psychology before I cover a little bit of the occupational therapy or the physical therapy? Okay.
And I'm thinking we may have muted because of some of the background.
Okay.
So if you do have a question, you can also type it in. There's a box on the bottom of the webinar. So feel free also to type any questions in there too in case you have been muted.
Thank you. Okay. So occupational therapy, really a huge part of the program because we're wanting people to return back to that function. So examining body mechanics, posture, lifting techniques. And a lot of people have never experienced occupational therapy. They've never been shown how to do basic lifting or maneuvers. In addition to that, some people were shown or knew before, but they have accommodated and made adjustments due to their pain and kind of workarounds that our OTs are able to kind of give them better techniques. The BTE functional simulator, I've had so many people come in and at the end of the program and they're like, I made 91% improvement in my ability to do certain tasks that machine measures. And it just, again, builds that confidence of, oh, I can make progress, I can move forward. Next slide. And physical therapy, it's a very assessment and evaluation focused process. And that's with the team as we all talk together, really kind of coaching and listening because we all hear the patients are telling us all something a little bit different. But it's not like the patient comes in and here's a standard treatment. It really is adjusted to the feedback that they are giving our physical therapist. And physical therapy is also really important in establishing the self-management message. Here's your home exercise program. Here's how you pace your daily activities. Here's what to do if you have a pain flare-up. And so really empowering the patients to take responsibility and having more coping methods they can do when physical pain does come. Next slide. Turning it back over to Dr. Hudson.
Okay, so we have 4 different programs, and each of these programs focus on a different patient population. Our headache population is very different from our musculoskeletal pain population, and the fibromyalgia population is unique in its own way. Recently, we've been adding a complex regional pain syndrome program, and we're still working out the details of that, as this is one of the most challenging pain problems that we deal with. Next slide. So let's talk a little bit about the problems with our treatment program. The problems really, as I see it, are one of access. These programs are intensive, they're expensive, they require patients to come several days a week, several hours at a time, and we get about 100 referrals a month into our program. Only about 50 of them usually end up coming for an evaluation, so we lose half of them right away. Then half of those that do come decide not to come for treatment, and it's not usually based on our recommendation. It's based more often on whether they think they can afford it, whether they could afford the time from work, whether their employer would give them time off to go through a program like this, and what their co-pays would be, et cetera. So that's something that we're continually trying to work on. And I am interested in trying to develop a cooperative approach with primary care networks that might work to deliver these services to patients in a way that is more successful in getting them into treatment. And I know I saw some planning for your group that is looking at this, and I think there's some excellent ideas there, and I think that we at Mary Friedbed would be very interested in interacting with you and case managers and saying, okay, how could we do this better, and how could we get it to more of our patients? Next slide. Just to say something about outcomes, the slide on the left is depression, and what we see is a marked improvement in the depressive scores of patients between evaluation and discharge. The green one is on evaluation, and the blue one is on discharge. And this is the CESD measurement scale that we use. Next slide. Pain catastrophizing, also something that goes down markedly in our treatment program. Next. This is the sickness impact profile. The higher you are on these scales, the more impact you're feeling, the more disability you're feeling from your sickness. And the blue-purple bars are on admission, and the burgundy bars are on discharge. That thin yellow line is the normal range. So you can see that on many of these measures, particularly emotions, home activity, recreation, social interactions, and sleep, we see them coming down into the normal range. We don't do quite as well with alertness or with work, but these are really marked improvements in a fairly short period of time. These programs are generally range in length from 8 weeks to 12 weeks, and with on average being about a 10-week period of time. And we often hear from patients that they say they can't believe they feel this much better in this short of a time period. It's almost like an intervention, like you might do with someone with a drug or alcohol problem, is that we so intensively manage them in this time that they really have ability to develop new habits and new ways of thinking. And we've been very pleased with how long this seems to carry through in terms of their management of their pain problem. Next. Care management. There's always, when you're dealing with acute pain, there's always a question, when do you switch from an acute problem to a chronic problem? And how do you deal with that differently? And there's a lot of judgment that goes into that. I think our system, our acute medical care system, really focuses on us trying to fix things. And there's a lot of things that can't be fixed. Of course, if it is fixable, that's what we all would like. But it's very important, I think, especially with primary care providers, that you try to help patients be patient with a problem that you know most of the time is going to get better. I think we're a little too quick to jump to imaging, x-rays, MRIs, especially when we know that often people with no symptoms at all are going to have abnormal MRIs. So we really don't want to order that until we're sure the patient really needs to go on to surgery or to some invasive technique. Because if their symptoms don't warrant that, we really don't want to do the imaging. It's just going to make it more difficult to get them better. We're trying to help, once we do determine that this is a chronic problem, then we really want to manage it as a chronic disease. To say, how can we avoid disability as much as possible and improve quality of life, even though, just like with diabetes, we can't cure the diabetes, but we can work with a good case manager to help a patient learn to manage these things themselves more successfully and feel better and do better and live longer with fewer complications. And the same thing in the chronic pain world. And I think diabetes is a good example of that. Next slide. I think what I would like to do, given our time, is to stop here and really ask for questions or comments on, has this been helpful? What other things would you like to hear from us? Please give us some feedback here so we know how better to serve you.
So Amy, Kristen.
All guests have been muted. All guests have been unmuted.
Okay. All right. Super. So lines are open, and here's your opportunity. So please ask your questions and give feedback.
Please. Sure. My name is Deb. I'm an RN care manager. I'm calling in regards to a patient, Louise Jewell.
Deb, we can hear your conversation, so if you could please put your line on mute.
I think.
So, folks on the line that are on the webinar, any questions?
Hi, this is Sarah Armstrong from Priority Health.
Hello.
Hi, I just wanted to give you some feedback. I was not previously familiar with your program, and I'm a care manager and work with our commercial care management team over at Priority Health, and so I'm glad I attended today, and I certainly will be sharing this information. I would love to be able to share the PowerPoint with the rest of the care managers. I know many of us were invited to attend and may be still attending a future opportunity or listening to the recorded.
Thank you.
But if it's possible to get a copy of the PowerPoint slides, I certainly would like to share this with our medical directors and our care management team because I think your work is very important and really focused in the right direction.
So, Sarah, we did record this session, so folks that were not able to attend, they'll be able to access the PowerPoint and the recording.
Okay, great.
They are either nurses or social workers. We have also applied for CE and received credit, so they can also get their continued education credits if they listen to the webinar and complete the evaluation as well.
Okay, great. I will definitely encourage people to do that.
Okay, and as far as Priority Health goes, our programs have had case rate contracts with Priority Health for over 15 years, and also with Blue Care Network. And those two products, with Priority Health, it's the HMO product specifically, where they have the insurer has provided lower copays and tried to decrease the barriers to patients participating in our programs. It's been a long and good relationship that we've had with Priority Health and with Blue Care Network in that area. And we would certainly, I think one of the things as far as going forward in learning to manage healthcare costs, I think it's important to recognize that there are certain population of patients who are ending up with multiple and serial surgeries and multiple medications and lots of pharmacologic costs for the system that would really benefit from this. And yet
I agree.
It's cheaper for them to get another surgery than it is to come into our program. And I would like to see if we couldn't work some way that we could lower that barrier and say, how can we get you off this treadmill of getting one surgery after another?
Yeah, I think that's phenomenal. And there may be many people who are aware of your program at Priority Health. I am somewhat new and in a somewhat newer role. I work with a lot of our self-funded key employer groups. So I suspect there could be some capacity to, potentially broaden our relationship or look at some new opportunities. So like I said, there may be people who are very familiar and people who are doing actively referring, but it is probably would be a good time potentially even to have you come in and speak at Priority Health if you'd be open to that and look for additional partnerships or opportunities. So I think that would be phenomenal.
Yeah, so just a quick thing, Sarah. MI-CCSI, the Michigan Center for Systems Improvement, is working with Dr. Fox, one of your medical directors, as well as others at Priority Health. As Dr. Hudson had mentioned that we're looking at, how can we in our community look at chronic pain and improve that and work with our primary care docs And Priority Health has been very supportive of looking at that model. So we are working with them to figure out how to support this.
Okay. Well, and I work closely with the key accounts, and I had heard nothing. I mean, I knew there was some work going on, but I really didn't have this level of. So I do think there's probably, it's a big organization, so there's probably some silos going on at Priority Health. But there's, so I'll connect with John Fox and talk to him a little bit further about what's in place and what's upcoming.
Yep. So more to come on that. Other questions as far as we have Dr. Hudson and Dr. Litterdale, their expertise on chronic pain. Any other questions from folks on the line? Well, maybe while you're thinking of questions, I've got a couple that I'd like to ask, and I'm interested. As care managers, they're working with patients that might be referred to a pain psychologist, a pain program. They might be having to connect that in lieu of having access to a fully team-based approach. What can care managers do or say to patients that as they're receiving services that they can help encourage the patient so they don't kind of get pulled down into that negativity? So what are some things care managers could converse with patients?
Well, I think for any provider, it's important, we've, I think, been given this idea that, pain is almost Norco deficiency. If you have pain, then you must need a really strong pain medicine. And what the CDC guidelines really say is that that's really not true. And I think it's very important to not get more people onto narcotics. And the first step in that is having providers understand that that's not a good way to go. It doesn't mean not using narcotics for acute pain, but to really limit the time frame you use. The CDC suggested 3 to 7 days for an acute pain. And I don't know how many of you have had surgery or had a baby or wisdom teeth pulled, and you took the pain meds for a day or two, and that's when you needed it, and then you wanted to get on with life, and you really didn't need them anymore. And so we've really gone overboard with the use of the narcotics, and we've made our patients afraid of having pain. I have a nurse that I work with at St. Mary's who likes to say, we should be asking the patients not how much pain they have, but are you comfortable with the amount of pain you have?
Yeah.
That's a different question. That's saying, okay, you've got pain, but are you comfortable with the amount? Can you handle this? And that gives a different message. It demonstrates less fear of pain on our part. And that helps the patient not be as afraid of pain, because it's the fear of pain that really winds up that issue. I could give you many different examples of helping people just calmly, and listen carefully to their description of pain. Don't argue with them and say you don't have pain, but listen to it in detail. What is the pain like, and how is that affecting you, and how have you been coping with it so far, and what else do you think you could do, and have you been taught other things to relax, and how are you doing with doing your exercises, and are you using your relaxation? And that, and doing it in a way slowly and calmly that helps them relax about it.
Yeah, we do have some slides towards the end that we didn't get to cover that do give a few tips on how to really work with patients. But I would say modeling the acceptance commitment approach is one of the big ways, like what is the values, what are your behaviors, using the same kind of things you might be familiar with, motivational interviewing or behavioral activation to really, while you're encouraging and accepting, really kind of challenging and pushing them to move into action. The acceptance commitment therapy, there is a lot online. They make it available to everybody to have access to. And Sue, I can probably get you the link to the website where that is coming from to share with the organization.
That'd be great. Yeah, so the other question, and I think you somewhat answered it, what type of homework do patients have? So they come to the team, and there's certain things that you're reinforcing, and so are there certain things that care managers understand that a patient does receive for homework and reinforce the patient to focus there?
Sure, and these are even some things you could do in patients who haven't been in the program. One of the things I always start out with a patient is asking them to walk me through their usual day. And you'd be surprised how many people tell me that they're not even getting dressed every day, that they don't get out of bed until the afternoon. And I give them homework of saying, okay, I want you to get dressed every day. I want you to set an alarm, maybe only an hour earlier than they're getting up now. But have them set the alarm, get up, get dressed. That makes them feel better about themselves, more hopeful about the future. They're little things. You want to start them with things that you know they can do, but it helps them realize that they can. They're often feeling very hopeless and helpless, and little things like this and little encouragements from anyone can help along the way.
Yeah, and in psychology, we give them homework about relaxation, guided meditation, provide them a lot of resources. And we start out with small amounts, and then build it.
Great. Well, unless there's other questions, I want to thank you, Dr. Hudson, Dr. Litterdale. Very wonderful presentation. I think some great tools and information for care managers. As a reminder to folks on the line, if you have not registered, please do so. And you can go to our website, www.mi-CCSI.org, and you'll see the registration area there. If you did register and you are seeking continued education, make sure you complete the evaluation and return that so we can give you your certification for attending the webinar. And we have a series going on, so we have another webinar coming up shortly on the chronic pain, and then another one on spinal cord and back pain. So I encourage you to look at those and the dates, and that can be found on our website as well. So thank you, everyone, and a special thanks to Dr. Hudson and Dr. Litterdale for your great information and empowering care managers. So thanks, everyone. And with that, we'll end.
Thank you.
Thank you.
Thank you.
Thank you.